Ahead and get started. I'm very excited to introduce Dr. Waseem Ahmad. He is a gastroenterologist who cares for patients with a broad range of digestive conditions and symptoms such as heartburn, abdominal pain, changes in bowel habits, and gastrointestinal bleeding. He provides colon cancer screening and works with patients on prevention. He also performs diagnostic procedures, including colonoscopy and EGD, use and examines the upper digestive tract extremely thoroughly and is a joy to scope with. He earned his medical degree at Rush Medical College and completed residency in internal medicine and a fellowship in GI at the University of California, San Diego, where he also served as a chief fellow. So it's with great pleasure that I will hand it over to Dr. Ahmad for our classic lower GI bleed talk.
All right. Thanks, Gloria. And then, are you able to see my screen okay?
Yes, it
Yeah.
looks great.
Okay, perfect. All right. Well, thanks for having me. And I see a lot of new faces now on the fellow side. So excited to have you all join. And I'm sure as you guys have already started, you've already seen some of these lower GI bleeding cases. So the goal for today is to kind of just go over a broad overview of, what to think about when you get these consultations for lower GI bleeds, what is best practice managements, and then we'll go over some kind of more common isolated cases that we should be familiar on how to manage. So no disclosures. And then, like I said, our objectives today are how to manage patients with acute lower GI bleeding, and then also how to manage anticoagulants and antiplatelets during both the bleeding and endoscopic period. So first off, whenever you had a consultation in the back of our head, we're trying to think of, different, causes and what our differential is. So you can see there's a lot of different causes of lower GI bleeding, namely diverticular, hemorrhoidal, but, pretty much you have the whammy on different causes. And it's very important for us to consider the kind of presentation for a patient because that might impact, the urgency of us potentially doing a procedure or getting a CT scan. And then also may impact, is this a supportive management versus more aggressive management? Factors that are associated with poor outcomes. So, when you get that initial consult, you're trying to think, okay, is this high acuity or is this someone have a little bit more time to kind of think about? So obviously, things that are a little bit more concerning would be if someone is in shock or is having hemodynamic instability, you're worried that this patient may have to go to the ICU. If someone's having, gross frank hematochezia that you can see, on rectal exam or, they're just spilling out stool in the ICU. If they have comorbidities, especially cardiovascular, renal, pulmonary issues that make them a little bit more unstable when it comes to just managing their hemodynamics, older age, and then also, prior history of either diverticulosis, angiectasias, just risk factors for them having bleeding cases. And then finally, elevated creatinine, hemoglobin, a lot of the markers that I think Colin had brought up to you guys during the upper GI bleeding talk kind of also relate to this. So, just like with upper GI bleeding, the initial management is focused on getting a good history and physical exam. Some of that is, very limited towards what do we know about the patient's prior history, prior GI bleeding events, and then also getting context of how much resuscitation or where are we at in terms of their prior use of Coumadin or an antiplatelet, because all of these factors will come into play about how do we triage this patient and ultimately how soon do we think about, does this patient maybe need a procedure or are they better off, getting, a CT and going from there. So we'll try to go one by one and go over things that we need to think about when you're calling patients back or calling the consulting teams back. So first off, focused history and physical exam. So you'll see as a fellow, your time is very sparse, and you really have to kind of triage patients, efficiently to get the best outcome. So from a history standpoint, it's going to be hard to comb over everything, within like the short time that you get the consult. But things to keep in mind, do they have a cardiovascular history or a specific cancer or renal history? The reason some of these can be important, obviously if they've had a stent placed very recently, say they're on aspirin and Plavix, or, aspirin and ticagrelor, and now you're wondering, okay, is this patient, safe to even hold one of their antiplatelets? If they've had a cancer history and it's metastatic, and now they're bleeding, that may change what therapeutically we potentially could do versus if this was just somebody that had a diverticular bleed. Renal comorbidities are important because the clearance of some of these blood thinners will change. And now we may or may not think about, using a reversal agent. Other things to keep in mind, you always want to know prior GI surgeries. So I think sometimes we don't pay as much attention to like what someone's surgical history was, but I think it's important just for the fact that if they had a recent surgery, the chance that there's bleeding from say like a fresh anastomosis or say localized ischemia, that could impact not only what we think about from a therapeutic standpoint, but that can also impact what the surgeons may want to know. If this was a fresh surgery and now a patient's having hematochezia, it's important to be in contact with the surgery team because they may or may not kind of want our input on what we see, or they may just think about taking the patient back to the OR. For any of these consultations that you get for any type of GI bleed, you want to know what their prior procedure reports are. So, in our system, just going under chart review and procedures tab is the easiest way. But if you go into Care Everywhere, sometimes you can dig up prior Kaiser reports or CPMC reports. And then other times patients, will have their families bring in prior reports or maybe scanned into the media. So even if you don't have enough time to, gather that all yourself, asking the primary team if they can help will also be helpful. The reason is if the patient's had a prior history of GI bleedings, if we know they've had a diverticular bleed or AVM bleed, that will also kind of shift, how urgent we think, our initial management plan would be. And also it can help us from a therapeutic standpoint when we go into a case. Pertinent medications and last doses of medications, namely aspirin, antiplatelets, anticoagulants, is very important. If we know someone is relatively stable and they had their, blood thinner held for a day already, then we have a little bit more time versus if somebody's just coming in and everything's on board. Now we have to start thinking, okay, is this someone we have to reverse or just be a little bit more cognizant that the bleeding may continue even though we physically see the patient. And then lastly, GI symptoms, are they having any other symptoms that would be associated with, a really frank GI bleed? For example, syncope, lightheadedness, dizziness, shortness of breath, namely things that you would think of with symptomatic anemia, because that could indicate that maybe this patient's final reserve is kind of wearing down and we have less time to work with. From a physical exam standpoint, a lot of this is going to be based on, vitals and hemodynamics. So when you get that consultation and, the team says, oh, the patient's having blood clots and hematochezia, and you take a look at their vitals and, their blood pressure is okay and they're not tachycardic, that gives me a little bit more time to, breathe and then just kind of think about the case a little bit longer while we mobilize the troop versus if someone is hypotensive, they're tachycardic, they haven't gotten anything on board, we're in the beginning of our outpatient day. That person's the one you're trying to tell the team, you really have to get this person resuscitated, keep an eye on their blood count. And now we're starting to get in that point where if we can't get to a potential procedure potentially, then a CTA and IR start coming into our initial management plan. When you go see this patient, obviously the vitals assessment and how they look is a good starting point, but then the abdominal exam and rectal exam can also be, useful. Abdominal exam, and we'll talk about it a little later if you're worried about somebody that has like mesenteric ischemia, and, say there's something more surgical abdomen type picture that might impact what we're thinking that we're going to find on a lower scope. Rectal exam or even just seeing, what does the stool look like? I'm sure with Colin's talk, there's a difference between melena versus maroon stools versus hematochezia. Same thing for us from a lower GI bleeding standpoint. It's one thing if the stool looks fresh, bright red versus more kind of maroon with clots, because that might tell us where potentially in the lower GI tract something might be coming from. All right, so to start off, resuscitation. So for all of these patients with any GI bleeding, it's very important that you get them resuscitated. So anyone with hemodynamic instability, suspected ongoing GI bleeding should get IV fluid resuscitation. And the goal is to get the blood pressure and heart rate tanked up. If you bring someone down to endoscopy and they're not fully resuscitated, even a whiff of, Versed and fentanyl, or when anesthesia gives propofol, it is going to tank their blood pressure quite a bit. And if you, for example, don't have access and now you're hypotensive and they're actively bleeding, you're setting yourself up for a catastrophe. So again, before we put the scope in, a lot of the onus is getting everything teed up, because a successful case often is just us getting everything appropriately pre-managed as opposed to anything that we do intra-op. From a blood transfusion standpoint, usually a restrictive strategy is the way to go. So the threshold hemoglobin is 7. Obviously, if it's someone with fresh cardiac concerns, it may be a little higher at 8. But for anyone hemodynamically stable, the goal is to get the hemoglobin to 7. There's always going to be a question on what do we do regarding like coagulopathy and antithrombotic management. Obviously, many patients are on aspirin, antiplatelets, anticoagulants. From a vitamin K standpoint, the goal INR ideally is under 2.5. You're going to have some patients that have mechanical valves and they're followed by the anticoagulation clinic and their Coumadin's on board and they're at 2.5 to 3.5. And then you'll get some patients that, they accidentally took too much or there was a drug-drug interaction and now they're coming in with a INR of 9. So now we have to think about how is the best way to reverse it. Some of it is going to be based on how acute that patient's presentation is. And then others, it may be, okay, how close are we goal to that 2.5? We'll talk about on the next slide about Kcentra versus FFP and life-threatening GI bleeds. For DOACs, there are reversal agents available. Usually, we haven't had to give these. This is often in combination with the ICU pharmacy team in case we had to. It's just important to know what options we have. But I would say between, reversing Coumadin because of a high INR versus reversing like dabigatran, the first is much more likely. And then lastly, coagulopathy. So everyone's going to have a different kind of threshold on when to potentially scope. Ideally, the goal platelets are going to be above 50 if you can. Obviously, that's not always going to be the case, especially, for example, if you have like a cirrhotic or someone who has like chronic thrombocytopenia. Ideally, if you can get it above the 20 to 30 threshold, anything kind of below 20, especially as you get down to 10, you already run the risk of iatrogenic or spontaneous bleeding, and it can make it much more challenging if you did have to do hemostasis, that you're a little less successful. So, when you see the platelet count hovering in that, 20 to 50 range, potentially giving some units, at least to run interop can be helpful. For aspirin, usually it's okay to continue if it's for secondary prevention, namely if someone's already had a cardiovascular history. They were on it for primary prophylaxis. Obviously, you want to stop. And then after you stop the bleeding, The question is when to resume. Usually for secondary prophylaxis, you would resume once it's safe. But that'll be a management plan that you would discuss with the primary team after the bleeding has stopped. Other antiplatelets, for sure, you want to hold initially. And then anyone with like a significant cardiovascular history, or say they follow with cardiology here at UCSF, may not be a bad idea to either let the medicine team know to see if they can just touch base with cards, or you just personally just ask cardiology what they think. The big things from a management plan is, yes, you are thinking about scoping or potentially prepping and thinking about their blood counts and transfusions. But a lot of the sedation risk or the risk with a procedure is the actually anesthesia. And what we want to do is make sure that they're optimized from a cardiovascular standpoint before we even think about a procedure. So just getting, cards input, not only about the blood thinners, but also, is this person, safe enough to undergo anesthesia? Because if they have some concerns, a lot of GI bleeds, depending on the acuity, we can actually kind of supportively manage. And that might be, a treatment plan for us rather than us putting them through a scope. So this is the kind of reversal strategy that you can think about. This is from one of the ACG guidelines, and all the references will be at the end of the PowerPoint. So for Coumadin here on the top, I think this is probably the most practical one. So life-threatening lower GI bleed despite initial resuscitation and a high INR. Your first option is going to be Kcentra, just for the reduction in INR speed as well as the volume given. Sometimes FFP is also given, but between the two, you would opt for Kcentra. You can see for dabigatran or the other anti-10A agents, we do have agents that can be used for reversal. I haven't seen it given in a while. Again, if there's someone to that level that they're going to the ICU, hemorrhagic shock, maybe a discussion with the ICU team and pharmacy team about it. But namely, holding their blood thinner and resuscitating and optimizing any other coags will probably do the trick for most patients. And then, as you can see on the bottom, most patients with lower GI bleeding on anticoagulation can be managed with fluid resuscitation, PRBCs, and then holding the drug. All right, so that's kind of the peri-op management. Those are the patients that you have a little bit of time to go see the consultation, kind of think about, how to best optimize someone, especially if they're not super, super sick or looking like they're headed to the ICU. Now, when it comes to diagnostics, say you get that patient, you're definitely worried about their eyeballing, not so hot, and you actually don't know if you're going to have enough time to like get from morning outpatient cases to like either an outpatient or an inpatient scope, either at the end of the day or the following day. So this is a patient that would come in with severe hematochezia. So they are just pouring out blood. The initial management is just like we talked about, IV resuscitation, getting their blood count up. But now there are a few diagnostic points you have to think about. Number one is, do we think there's any chance of a rapid upper GI bleeding? So as Colin kind of discussed with you guys, there are certain parameters that you would think, okay, how acute or how severe an upper GI bleed would be, namely hemodynamics, what is their BUN creatinine, do they have melena, maroon stools, probably in the setting of like a really severe upper GI bleed. But if you don't feel that's the case and you think that this is lower down, now you have to kind of stratify. Is this someone that really is pouring out blood, hemorrhagic shock, or is this someone that has a little bit of bleeding, but they're otherwise stable? So if you start off on the right side of the algorithm, a mild lower GI bleed, or say you had some bleeding that has kind of gone away, that person, if you sent to a CT scan, probably the velocity of bleeding is not enough that the CTA would pick up anything, in which case, there really wouldn't be a role for IR to go after. So that's a patient, as you can see, that you would probably admit to the medicine service. You would start them on a bowel cleanse. And then, the ideal thing is they kind of clear out while you're trending the hemoglobin, you're managing their hemodynamics, and you would think about doing a colonoscopy the following day. On the other hand, if you get the patient that, they're coming in, you're seeing frank blood with blood clots, they don't look so hot, their hemodynamics are borderline, that person, you have to recommend a CTA. For us, the all the things that entail like getting a good colonoscopy done for lower GI bleeding, think about it. You have to do all the peri-op management we just discussed. You have to get a good bowel cleanse, which if they're already kind of struggling and, lightheaded, it's going to be hard for them to drink 4 liters of bowel prep. Putting in an NG tube and just clearing them out. All of that takes time. And for someone that's having significant bleeding, the CTA and getting them to IR is going to win out. So if you get a CTA, what is it going to show? It'll either show active extravasation or it won't. If it doesn't, then there isn't anything necessarily for IR to go after right now. In which case, likely you'll go with a bowel cleanse. On the other hand, if they have extravasation or you don't think that this person is someone that is in any candidate of doing a bowel prep, or you just don't think that an NG tube with prep is going to be, salvageable, then that person, you should have them, medicine team, call IR just to see if they can consider embolization and find a source. And again, a lot of times when we get called on GI, it's about doing a scope or not. But for us, for lower GI bleeding, you have to realize CTA is part of our management plan. It should be right up there. So if you get someone with an acute presentation, don't feel bad. We're not doing a colonoscopy. CTA is the correct move. So again, the role of the imaging. Any patient, hemodynamically significant hematochezia, CTA should be the initial diagnostic test. Again, very low yield if someone has, say, for example, like stable hemorrhoidal bleeding or mild radiation proctitis. And then, IR is the way to go for this specific case. Now, the role of colonoscopy, sometimes the question is, okay, the patient has a lower GI bleeding. When should we think about doing colonoscopy or not? And is there a certain time period to go ahead and doing it? Usually a non-emergent inpatient colonoscopy isn't preferred without doing like a full bowel prep. And I'm sure, many of the older fellows have already done these cases, and, the younger fellows, you'll probably get a case where someone's not prepped and you're going to do a lower GI bleed case and you think you're going to find the source. You go in and it is all red all the way through. It can be very, very challenging to, number one, clear everything out, get all the way to the TI. Now you're in the TI and you're wondering, are they bleeding from the TI or is it blood that refluxed back? And say they have ticks along the way and you're cleaning everything out, and it just gets very challenging to know if something really bled or it's bleeding that has started and stopped. And so for us, from a safety perspective, doing the colonoscopy after there's been some level of prep is important. And then also just from a therapeutic and rebleeding and mortality standpoint, you're going to be better off just waiting until they're more optimized. If you did have to do a bowel prep, kind of doing just the normal 4 to 6 liters that we would do for like a typical inpatient bowel prep is okay. Split-based prep, low volume preps can also be used. The one scenario where we would think about potentially going in, say, same day, or maybe not necessarily having to do like a full day prep, is if you have someone of high suspicion that the source is distal and it could be reached by a flex sig, then that person you may consider giving a couple enemas and then try doing their scope later that day. Examples of this would be if you have someone that has a known diverticular bleed every time from the sigmoid, or someone that has a history of radiation proctitis, someone that had a recent, large polyp removed from the rectum or rectosigmoid, um, and you're worried about post-polypectomy bleed, or lastly, someone who's been in the ICU, they've had a rectal tube and now they're putting out blood. That might be someone that you can reach with just doing a sigmoidoscopy. And while we may have a CTA, we may have IR on standby, in that scenario, it may not be unreasonable for us to go in first, see what we can do, and then if we really can't find the source or it's challenging, then we have IR as our backup. But again, if it's something more proximal, cecum, ascending colon, this strategy is unlikely to work. All right, so the final part of the presentation is to kind of go over some kind of select cases that you're gonna get consulted about or think about on kind of how to manage or what to expect. And again, this is more to think about, okay, pre-op or pre-case, what are the things I have to keep in mind? And then once I'm intra-op, what is my, kind of hemostasis agent of choice, and how do I play it forward if I can stop the bleed versus I can't stop the bleed? So just like the first slide had showed, what are the most common causes of lower GI bleeding? So diverticular bleeding is going to make up a third to a half of cases. So this is when an artery in the neck or dome of a diverticulum ruptures. Classically, it's going to be a patient that comes in with painless, brisk passage of red blood and clots. If this is more proximal on the right side of the colon, then you can have more maroonish stools or melenic stools. Just from a kind of observation standpoint, many of these cases will stop on their own. Obviously, it can be kind of frustrating where you see overt bleeding and then you're expecting to find something, and then by the time you go in, there isn't anything that's still actively bleeding. Common patients will be, someone who is elderly comes in, who's feeling symptomatic anemia. Their blood count was 14 last month. Now they're coming in at 8. You have someone that's otherwise, robust, and now they're just putting out blood. That screams like diverticular bleeding. Even if someone looks okay, it may be reasonable to get a CTA for that patient, even if you're not thinking that, oh, this patient's going to necessarily need IR embolization, because at least it would give us a roadmap on where potentially the bleeding can be. You'll see a lot of patients have pandiverticulosis, and if that's the case, any of those diverticulum are fair game. Many patients, though, a lot of their diverticulosis burden is in the sigmoid colon. And so if we get a CTA and then see that there's bleeding that's coming from the sigmoid, then, potentially that allows us to go after it same day, or at least if they prep, gives us a better shot at finding the source. Here on the right side, this is from a picture from DDSEP, and we'll kind of show a video on the next slide. You can see that there's fresh red blood that's coming from a diverticulum. Usually clips are the way to go in these cases. Sometimes it's obvious like this, where you can see fresh, bright red blood that's coming from a tick. In practice, you'll see that every diverticulum has a little clot in it, and it's hard to know if that was the source or not. Usually, if they had some level of prep, and you go in, there's usually one or two diverticulum that have clots that are coalesced in one area. So that should be kind of the clue that A, someone had a diverticular bleed that has stopped, and then B, that might be the person that we kind of try to unroof that clot and see if there's something there that needs to be clipped. All right, so let me just get this going. All right, so this is what a diverticular bleed would kind of look like in practice. Again, so this patient's prepped, and so the mucosa all looks good, and then you can just see it's like fresh, bright red blood that's coming from this area. And when you have a little time, and when we do like outpatient colonoscopies, and you take out a polyp, and you're worried about, okay, do I need a clip or not clip? Just sit there and see if something is oozing or bleeding. If you really had hemostasis, it's going to stop after, 10, 30 seconds. And so like in this case, if you have something that's kind of oozing, persistently oozing, just keep an eye on it. And if you're worried, you can place a clip because if you take this patient, say we had a patient came in with diverticular bleed, we think we found the bleed, but we're not 100% sure. What I would do is I would place the clip. I would say in the report, suspected diverticular bleed. I would let them know, hey, I found a few clots in this specific area of the colon, and a clip was placed. So the benefit of doing that is number one, you in theory have stopped the bleed at the time, but also if this patient bleeds again, whether it's myself or say a week later or a year later, a patient comes in with bleeding, most likely the patient's going to be bleeding from the same location. So it
Yeah.
gives us an idea that a sigmoid diverticular bleed is the cause, and we would go after that again. And then also, if something were to happen, say a day later, 2 days later, then you would just say, have radiology, do a CTA, and then maybe prophylactically go after the clip site. So there is some utility of us at least marking where we think a bleed was. All right, so another common cause of lower GI bleeding, this is a little less acute. This is radiation proctitis. So, any patient that's had a history of like bladder, cervical, rectal or prostate cancer, they've had potentially radiation to some degree. And everyone varies. A lot of patients don't have any symptoms. If they do have symptoms, they actually have more just kind of outpatient GI dysmotility, bowel movement issues, but bleeding definitely can happen. And, for us, the treatment strategy is doing APC or argon plasma coagulation. You can see on the right, this patient has extensive, vascular pattern. But for many patients, it's not to this level, and you can have some discrete lesions that you can go after. The big thing to know for these patients, usually you want them to at least have had a couple tap water enemas to make your field cleaner. If you don't have a clean field, it can make coagulation a little bit more challenging. And for these patients, often as an outpatient, you're going to bring them back, serially until you can kind of zap and kind of destroy all of these blood vessels. These are the patients that are not going to show up typically as, hemorrhagic shock or a CTA would offer us too much. But if you get the consultation, you know that they've had radiation history, their level of bleeding is, daily, low level. That person, you're thinking a little more radiation proctitis, and you probably have more time to think about either doing a full bowel prep and a colonoscopy if they've never been scoped versus if their prior scope history is to just getting them ready for a flex sig. So this video is going to kind of show what we typically would see with APC as well as with radiation proctitis. So for this person, so a few main things. So you can see the mucosa otherwise looks, nice and healthy. You see obviously a pretty extensive, kind of ABMs all throughout. And then the good news here is the prep is cleared out. So you've cleared out all the liquid. So this is going to give yourself the best shot at getting the APC to work. And as we fast forward a little, once we start zapping these guys, you're just going to pass out your blue APC probe, and you have straight fire or kind of side fire. For most of these patients, going with a straight fire usually will work better. And then all you're doing is you're just hovering over each blood vessel and zapping it one by one. One mistake that can be done is if you just go to town and just try to zap everything in one go. Usually that will destroy the tissue, but maybe will actually lead to more prone bleeding. So what you want to do is actually just do it the way they're doing here, which is zapping it individually, stop, find a new vessel to go after. Again, most of these radiation proctitis is not going to have it to this level, and you may have to bring this patient back, in a couple of weeks or a month. You have other topical agents that can bridge things over as an outpatient as well. So it's just important to know, peri-op for these specific cases is you want to make sure that you have a good prep and you're really setting yourself up for the optimal response for APC management. All right. So the next one I wanted to highlight is ischemic colitis. So again, the reason I want to bring up this is a lot of the management or decision plans that we've talked about so far is really us versus IR on who to take the lead, or if we go first and we can't stop things, then IR is our backup. But this is one of the few scenarios where it's going to be us and surgery kind of deciding what to do. So ischemic colitis, namely hypoperfusion of the watershed area where two blood supplies meet. It's not as common of a cause of lower GI bleeding, and many of the kind of management principles are just supportive management. Where are you going to see this? Either the splenic flexure, where someone's going to have like cramp-like abdominal pain, possibly lower GI bleeding, versus the hepatic flexure, where you're a little bit more likely to have some pain with some passage of clots. The reason this can be important is number one, from an endoscopic standpoint, the sign that is commonly seen with ischemic colitis is something called the stripe sign, which if you can see here on the right, you just kind of see that pale white mucosa, which essentially is a stripe along the antimesentery of the mucosa. The reason this can be important is if you have someone that is, say, coming in with abdominal pain, has lactic acid that's elevated, and say they had a recent vascular repair or a recent surgery. Now you're starting to think, okay, is this a surgical consultation or not? And for this patient, you may want to discuss with surgery about, hey, this patient's having hematochezia. I think it's ischemic colitis. They probably got a CT that showed some, mural thickening along one of the flexures. And you can discuss with them, number one, this is what I think is going on. We probably will go in with a scope, but this way, this patient is on their radar because there are some, very fresh surgical patients that the surgeons actually don't want us to go in, and they would kind of opt for either conservatively just monitoring, or they're just going to take back to the operating room themselves, or they may be holding an OR for this patient, and they're going to say, hey, go in, take a look. And then they may come into the case to watch, or they may want to see our report, because if we go in and there's a little dusky bowel, that's a slam dunk. This is a ischemic bowel. This patient needs to go to the OR, or else they have to come in the middle of the night when they're septic. So again, if you're worried about ischemic colitis, it's good to kind of discuss with the medicine team or the surgical team about what we're thinking. And then again, this goes into pre-op management. How do you optimize this patient's care? And so getting all the consulting teams kind of on board and everybody on the same page so that the time the scope is in, we have a decision point on what we're going to do depending on what we find. All right, and then the last one that I wanted to bring up, and this is a common one that sometimes we forget, is solitary rectal ulcer syndrome. So, some of the bleeds that we showed before, diverticular bleed, ischemic colitis, that feels like acute. That feels like, oh man, it's us, IR, surgery, and ICU, and there's skin in the game. But I want to say these patients who have been in the ICU, they've had a rectal tube for a while, they can bleed a lot, and they can bleed exactly the same way as someone that's having like a massive lower GI bleeding from diverticular bleeding. So you can see here on the video, this patient has two large ulcers, and you see a few visible vessels within the ulcer bed. And the reason this, is very important is like, if you see, if you have rectal tube in for like several days and it's causing, pressure and tissue destruction, that person's going to bleed. And because it's so distal, it's going to look super, super fresh. And so it's something to keep in mind when you're talking with the ICU team about, okay, how long have they had a rectal tube? Can you discontinue it? And then this may be a person that before you think about going for a CTA, are they stable enough to even do like a flex sig or even unprep? Because uh, probably the source is going to be from 0 to 10 centimeters in. And if you can at least get somewhat of an idea, this might be someone you can clip and puristat and namely take away the offending agent, which in this case would be a rectal tube. So overall, these were kind of the highlight cases I want to bring up. The management plan for any GI bleed, and this will go into Sarah's talk going forward, is you just want to have everything optimized before you put the scope in. And that's also coming up with a plan with your tech. So knowing what agents that you have available. So remember what we have at our disposal. We have different types of clips. We have Ovesco, we have APC, we have bipolar, we have hemospray, we have Puristat. You may need multiple things, and sometimes you don't know which one or multiple things are available. So the most important thing is discuss with the tech that, hey, we have all of this available. I think it's a diverticular bleed, or I think it's an ulcer bleed. Our plan is, as long as nothing looks too crazy, we're going to clip and then we're going to puristat. And then the medicine team knows, depending on what we find, that IR is on standby or surgery is on standby. That way, there's no lapse in like the management plan for the patient. And then overall, we did the highest care that we can provide. So with that, I'm happy to take any questions about the talk or just kind of, basic lower GI bleeding questions.